Good afternoon, and thank you for joining us for today's webinar, Health Market 2.0, Vulnerable Consumers and Health Information. Today's webinar is part of an Oliver Wyman, Foley and Lardner sponsored web conference series entitled Providers Plus, in which we have taken a look at the broader context of healthcare. My name is Alexis Bortnicker, and I'm Senior Counsel on the Healthcare Industry Team at Foley and Lardner. My practice focuses on assisting providers with reimbursement-related contracting and regulatory issues. There is significant focus today in healthcare on redesigning care and engaging patients in their care decisions. Today, we will be focusing on health information access for vulnerable consumers. I am honored to have the opportunity to moderate today's panel. We are lucky to have a distinguished panel of speakers who will be joining us today. Before I take a second to introduce our panel, I just wanted to run through some housekeeping matters for those who are listening. To begin with, for those who are applying for CLE credit with today's program, please note that today's program will run for 1 hour of instruction time, and we will apply for 1 general CLE credit. Anyone wishing to receive credit for today's program must enter the code when announced. When it is time for you to enter the code, a box to enter the code will appear on your screen for approximately 30 seconds. Everyone seeking CLE credit must enter the code in the box on their screen at that time. All New York, New Jersey, and Kansas attendees applying for CLE credit must also fill out an attorney affirmation form and write down the course code. The attorney affirmation form and a copy of today's slides can both be obtained in the resource list widget at the bottom of your screen. For New York attorneys, those of you with less than 2 years of experience will not be eligible for CLE today. Completed attorney affirmation forms should be emailed to Christina Wade, and her email address is cwade@foley.com, and that's also, I believe, on the form. CLE certificates will be sent to eligible attendees via email in approximately 8 weeks. I also wanted to note that questions for the panelists can be submitted by entering them in the Q&A widget on your screen, which should be open on the left side of your screen. We will do our best to answer questions at the end as time permits. With those matters out of the way, I wanted to introduce our distinguished panel of speakers. To kick us off today, we will be hearing from Puri Garg of Oliver Wyman, who will walk us through the research findings of a study performed by Oliver Wyman related to the provision of health information to vulnerable consumers. Puri specializes in playing at the seams between health plans and provider organizations and is recognized as a Medicaid expert within Oliver Wyman. She leverages her passion for serving the underprivileged populations while developing Medicaid-focused strategies for health plans and provider organizations alike. Prior to joining Oliver Wyman, Puri was a scientist in the psychological chemistry department at Genentech. She has a PhD in genetics and biochemistry from Washington University School of Medicine in St. Louis and a BS in biology from Illinois Wesleyan University. She has published several blog posts and papers on Medicaid in addition to peer-reviewed publications in scientific journals. Following her initial presentation, we will turn to our panelists for additional insight. Joining us today, we have Mishi Knight from the Robert Wood Johnson Foundation, Dr. Esteban Lopez from Blue Cross and Blue Shield of Texas, and Elaine Yoakum representing Martin Luther King Jr. Community Hospital. Mishi Knight is a program associate with the Robert Wood Johnson Foundation. She contributes to the foundation's efforts to transform health and healthcare systems. Her work focuses on ensuring that families living in communities have access to high-value, affordable, integrated care that helps them stay healthy and address their full range of needs. Her current body of work includes efforts that examine payment reform for population health, enhancing hospitals' roles in improving population health, and transforming care for individuals with complex medical and social needs. Mishi sees her role as the ideal confluence of her background, education, and a passion that's rooted in her deep personal experiences. Mishi earned a BA from Howard University and an MA from Trinity College. A quick note on the Robert Wood Johnson Foundation. The foundation is the nation's largest philanthropy dedicated solely to health. Since 1972, the foundation has supported research and programs targeting some of America's most pressing health issues, from substance abuse to improving access to healthcare quality. The foundation is working with others to build the national culture of health, enabling everyone in America to live longer, healthier lives. Next, we have Dr. Esteban Lopez. Dr. Lopez serves as the newly appointed Chief Medical Officer for Blue Cross and Blue Shield of Texas, where he helps fulfill its mission to improve the health and well-being of its 5 million members. In addition to serving as the executive sponsor for Texas government programs, Dr. Lopez leads the Community Investment Department in its long-term strategy to improve public health. He also holds the title of Market President of Southwest Texas. Previously, Dr. Lopez worked as a practicing physician with nearly every hospital system in the San Antonio community, and he continues to maintain involvement in the medical associations on a local, state, and national level. He also serves the San Antonio community in his roles on the Whitty Museum Board of Trustees and the Mayor's Fitness Council Executive Committee. As an active member of the San Antonio Hispanic Chamber of Commerce, he is recently elected as a 2017 chair and currently participates on the Executive Board of Directors. In acknowledgement of his efforts, the San Antonio Business Journal recognized Dr. Lopez with the 2015 C-Suite Award. Dr. Lopez is dual board certified in both internal medicine and pediatrics and received his training at the University of Texas Health Science Center at Houston. He holds degrees from the University of California at Santa Cruz and Michigan State University's College of Human Medicine, in addition to a master's in business administration from a combined program at the University of Texas at Dallas and UT Southwestern School of Medicine. And lastly, we have Melaine Yoakum, an independent healthcare consultant who is currently filling an interim leadership role for the formation and startup of the new Martin Luther King Jr. Community Medical Group. For several years prior, she served as the interim CEO and interim CAO of Martin Luther King Jr. Los Angeles Healthcare Corporation, a startup nonprofit entity. The nonprofit community hospital opened its doors in 2015 to serve the communities of South Los Angeles. Most of the South Los Angeles communities served by this hospital and medical group are HPSAs, or health professional shortage areas, as well as medically underserved areas. Bringing her experience in mature managed care delivery systems to this underserved community has been a highlight of her career. I wanted to give you a quick word on the MLK Community Hospital and the MLK Community Medical Group. The 1.4 million people served by the hospital and medical group have historically been one of the most underserved communities in greater Los Angeles area. The payer mix is 84% Medi-Cal and 10% Medicare. The population is 73% Hispanic and 19% African American. The community has the worst health disparities in the greater Los Angeles area. Physician shortages were some of the largest challenges to opening the hospital and beginning the medical group. While the United States has an average of 262 physicians per 100,000 people in the population, the community served by this hospital and medical group has 39 physicians per 100,000 population. The 131-bed general acute care hospital opened its doors in May of 2015, and the medical group is organized as the Friendly PC, has applied for tax-exempt status, and will open its first office with its first 2 physicians within the next 3 weeks. Welcome, panelists. With that, I will turn this over to Pari, who will get us started.
Good afternoon, everybody. Thank you very much for taking the time this morning to hear from us. As Alexis mentioned, I'm particularly passionate about this population that the Robert Wood Johnson Foundation has sponsored a study on. And so for me, as we went through this work, some of the insights and findings that we discovered were not only surprising, but hopefully provide us with a platform to spur some of the payers and providers and government entities that work with these populations into action. So with that, let me tell you a little bit about what the study was about and how it was structured. So if you could go to the next, actually I'm able to advance. Never mind, we're good. Okay, so on the slide that you have up on the screen right now, that shows you the overview of the study that was conducted. And the study was conducted by 3 parties. So the Robert Wood Johnson Foundation, Mishi Knight is the representative for them today, and she's on point to answer any questions you might have on that front. But they're the ones who sponsored the study and commissioned it, given their philanthropic leanings. And then Oliver Wyman conducted a portion of the research, and a portion of the research was conducted by the Altair Institute. As Alexis mentioned, the goal of the study was to understand how vulnerable consumers both receive and process healthcare information. And by vulnerable consumers, we mean those that are on Medicaid, those that are uninsured, people that don't speak English, etc. And so one part of the study was to understand what specifically consumer needs are from a healthcare information perspective. And then another portion of the study looked at the healthcare marketplace to understand how the healthcare marketplace considered provision of information to these individuals. The hypothesis is that with the healthcare marketplace being as complicated as it is, and with the provision of healthcare being as complicated as it is, even the most savvy healthcare consumer has trouble digesting the information that's provided, and that vulnerable consumer segments end up getting left behind in the equation. And so for today's work, I am going to primarily focus on the consumer findings that were discovered during the course of our study. For that, we surveyed approximately 4,000 consumers through a web and mail-based survey. And then in addition to that, we also conducted a number of focus groups and structured ethnographic interviews that gave us a lot of the rich nuance that a survey is not necessarily able to answer. If you're interested in more information about the marketplace research that was done, I'd be happy to share that information with you offline. We have a number of publications on that front. There's a paper that was published based on research that we did of over 100 stakeholders in the healthcare space, spanning payers, providers, technology companies, innovators, government entities, etc. But in the interest of time, we're going to limit the majority of our talk today to consumers. So with that, let's go over what we found in our study. For the most part, we sought to answer 4 key questions. As you can imagine, there are many nuances that existed in the survey study that weren't captured here. But the major questions that we looked to answer were, 1, what are the needs and frustrations that consumers face when they're navigating the healthcare landscape? What are some of the barriers that prevent vulnerable consumers from accessing information? How is information most commonly accessed by vulnerable consumers? And then who are the most engaged users of healthcare information? So one of the first things that we discovered with the survey was that really for vulnerable consumers, it is all about cost. Truth be told, this wasn't a super surprising finding because I think if you were to survey anybody, even those that wouldn't necessarily classify as being in the vulnerable consumer segment, most people would say that cost-related information is not very easily available for any healthcare consumer. And the interesting thing here is that we were able to do this comparison between individuals that made under $50,000 and over $50,000 on a household basis. And while everybody felt the lack of cost information most acutely, the vulnerable consumers perceived it much more sensitively than those that had household incomes of over $50,000 a year. Then the second thing we found, and this was one of the most surprising findings during the survey, was that vulnerable consumers tend to feel very disrespected by their providers. And so you might ask, well, what does that mean? People talked in the focus groups and during the structured ethnographic interviews about things like, I walked into the physician's office and he wouldn't even make eye contact with me. Or I'm a pregnant woman on Medicaid. I walked into my OB's office and she took a look at me and said, oh, you're pregnant on Medicaid, huh? And she said that she just felt really judged that she was on Medicaid and she was having a child. So stories like that came out that, one, I think provided a lot of real-world nuance to what we heard in the surveys. But then even more interestingly, what we discovered was that if people don't feel respected, they're much less likely to stick to their medication regimen. So we even heard a story about a woman who said, I went into my physician's office, he talked to me, and then he gave me this blood pressure medication. He didn't even touch me. He didn't do anything. That medication just sat in my purse. I never took it. He didn't care about me. So those sorts of stories and the data to back it up not only surprised us, but when we surveyed the market once these results were released, plenty of people that we talked to said that this level of information was something that was surprising to them as well. They knew that there was a feeling of disrespect. They didn't realize the correlation that existed with not being adherent with the treatment regimen. We also discovered that for Spanish speakers in particular, they struggle with language a lot. And while that wasn't a surprise, one of the things that did come out during the course of the survey and the ethnographic research that we did was that Spanish speakers, even if there was a Spanish translation available of materials, they felt very ashamed asking for it. They felt that if they went up to their physician or the nurse and asked for information that was provided in Spanish, they would automatically be judged. And one of the people said during the focus groups that, if I go up and I ask for it, they're going to look at me like, oh, not another one of these people again. So there's a little bit of the commingling of, one, difficulty of getting information in a format and a language that you're able to understand, but also bringing back those feelings of disrespect that we saw on the previous page. Another thing that was interesting from the Spanish population was that more so than the English-speaking population, they sought out advice from friends and family very, very often. And they relied on their advice as much as they relied on websites. So a lot of the Spanish speakers actually assumed or indicated that they considered that their friends and family were as accurate in terms of provision of medical information as some of the medical websites out there like WebMD, iTriage, and others. Okay. So then we asked, once we discovered what were the barriers when it came to actually getting healthcare information, we asked, all right, well, what are the most common ways of accessing healthcare information? And so this finding that you see up on your screen is again no surprise. Everybody said that they use Google as their first line of defense when it comes to getting healthcare information. Again, this is not true of just the vulnerable population. This is true of everybody we surveyed. This is true of me as well. It's usually the first place I go if I'm diagnosed with something or if I want to look something up. The difference was that with the lower income population or the more vulnerable segments, they didn't know the precise search terms to look something up. So as an example, if somebody was looking for diabetic neuropathy, they would just look for diabetes. And they would tend to get frustrated because it wasn't getting them the exact information that they wanted or needed. The other thing we discovered was that when the vulnerable population looks for healthcare information, if they stumble upon tools like cost comparison tools or reviews or things like that, they found those resources invaluable. One, they didn't know that they existed, and two, they didn't necessarily know to look for it. So it was harder for them to get access to those types of tools and services. We also discovered that with this group in particular, mobile is really the way to go. And so pretty much everybody said that they utilize their mobile phones as their means of accessing information, no matter where they are. We heard stories about things like, well, I don't have a computer at home, or I don't have the time to go to the library, and so my window to the internet is my phone. We also heard that if websites were not mobile compatible, that people gave up on the websites pretty quickly, and rather than try and find another means of accessing the information online, they just called. And so, they said that they didn't bother looking around elsewhere. They just straight up call the provider or call the health plan directly. We also heard, and I referenced this obliquely during the Spanish-speaking population slide, but we also heard that people rely very, very much on their friends and family, much more evident in the Spanish-speaking population, but it's even true in the non-Spanish-speaking population for certain things, particularly when it comes to choice of doctor. So if people are looking for a particular physician, they would tend to ask their friends or family or even take a look at patient reviews online. However, if they were looking for a particular facility to go to, they would not necessarily go to friends and family. They would rather go and look at their insurer website or other websites to figure out where they should go for care, or there was a big locational aspect to it as well. However, when it came to choosing a physician, word of mouth and understanding other consumers' experiences were key. Okay. The other thing we found was that in terms of who engages the most with healthcare information, caregivers far outperformed non-caregivers in our survey. They were much more engaged in pretty much every aspect of healthcare information that we looked at. There were a couple of reasons for this. They talked about the fact that, they felt a responsibility for the adults that they were taking care of or the children that they were taking care of. And then the other thing that they mentioned was that although they were very good at finding information for the individuals that they looked after, they had a very difficult time finding information for themselves. And by that, I mean things like respite care or financial assistance or just something to reduce the stress load that caregivers face. One of the things that was discovered during the survey that's not represented in the slides here was that caregivers tend to experience stress at approximately double the levels of non-caregivers. And so for them, having access to resources and tools that make their burden easier was a big deal. And unfortunately, they weren't able to find it, partially because of non-availability. So with that, let's talk a little bit about how these findings could potentially impact health plans and providers as an example. So one of the first things that health plans and providers could think about is how to rebuild provider trust and respect. Obviously, there's a reasonably large correlation between respect and medication adherence, and there are a number of ways in which this could be addressed. We talked to a couple of folks that had ideas such as, well, maybe our physicians could be shadowed by a non-physician who will pinpoint areas where they could behave a little bit differently. Right, so there's a big training aspect of it that's involved. You're treating consumers equally regardless of their background or regardless of their coverage. Health plans could also play a role by considering new reimbursement mechanisms or adding incentives for bedside manner if they don't already have them, or tweaking their bedside manner measures to align better with this population. Second thing is to think about providing both accessible and simple information. So make sure that information that you want consumers to get is mobile friendly, it's easy to find, and use simple language that everybody can understand, 4th grade or 7th grade reading level. Have language options available. One of the health plans that we talked to said that as a matter of course, in the communications that they provide to individuals, the front portion of it has English and then the back of it has Spanish. So nobody has to step up and ask and take that extra step to get the information. And then of course, and this is true, the last bucket here is true of both vulnerable and non-vulnerable populations, which is to make sure that cost and transparency information are prioritized. As most of the people on this call know, with President-elect Trump ready to take office in January, we know that one of the big impacts of that will be more consumer transparency, especially if Healthy Indiana 2.0 serves as the model for the ACA. That will have some pretty big implications here in terms of the number of individuals that will be on HSAs or using their own dollars to buy healthcare services. And so this issue of cost and transparency becomes even more important than when we had started down the study in the first place. Then a couple of other things, making sure that the community is appropriately engaged during any kind of outreach campaign. So churches, schools, grocery stores, etc., since we know that people tend to listen to their community and their network, even better than insurers, and sometimes second or third only to their providers. And then finally, since caregivers are such engaged users of healthcare information, we do believe that there's opportunity to engage them more meaningfully in the provision of healthcare information. And so if a caregiver comes in with a patient, instead of engaging just the patient, the caregiver should be engaged more meaningfully. You may want to think about providing resources for the caregivers or even targeting information to them such that they are able to utilize all of the resources at their fingertips to treat their family members and loved ones. Okay. With that, I'll turn it back over to Alexis to take us through the panel questions.
Thank you very much, Puri, for those insights. With that, I'd like to turn some questions to the panel to get some experience as to how their organizations are handling this information or making changes in this space. So my first question will be for Dr. Lopez and Ms. Yoakum. And the question is, how will the findings of the study impact your organization, and specifically with regard to your consumer information strategy and what your organization is doing to address information access issues for these vulnerable populations? And so if it's okay with the panel, I'd like to start with Dr. Lopez.
Sure. Thank you so much for the question, and thank you, Puri, for a wonderful presentation. You know, the work that's been done has really validated a lot of the work that we've done internally at Blue Cross Blue Shield of Texas. We did a similar study that compared the Latino population in South Texas and dividing it in Latinos along the Texas-Mexico border and Latinos in what we saw in Upper South Texas. And a lot of the issues that were pointed out, such as the need to feel respected when you're seeing a provider, or being able to address language barriers, or the role of friends and family and the social network, all came back to us in that study as well. So the work that has been done by Oliver Wyman has served to be able to validate that. And how that's influenced us is how we impact a population is going to be dependent on where they live and what are the social norms within that community, and really trying to figure out what is going to be the most meaningful aspect to that. You know, one of the things that we saw along the Texas-Mexico border was that 37% of folks that had private insurance had a regular doctor that they considered to be their primary care doctor on the Mexican side, and that they were going to Mexico because they viewed that health care to be higher quality. They saw themselves as getting white glove service. So what we learned is that despite the fact that the entire ecosystem of the Texas-Mexico border on the U.S. side is around 90% Latino, the physician workforce is not. It's roughly about 25 to 28% Latino. So getting more Latino physicians, or getting physicians who have cultural competency with regards to Latino patients, is important to us as a health plan. So finding tools and solutions around that has been an important part of the work that we're doing in South Texas.
Thank you. And Ms. Yoakum?
Well, sure. I represent Martin Luther King Community Hospital and Medical Group. We are a completely new greenfield hospital, small community hospital, 131 beds, that just opened its doors a little over a year ago in the South Los Angeles community. We had the wonderful, I believe, the wonderful privilege of being in the community prior to having a hospital or any physicians there. So what that allowed us to do was to do a lot of very similar surveying work. We went out and met with the federally qualified health centers, the FQHCs in the community. We went out and met with the other providers of care, both formal and informal. We talked to faith-based organizations, to schools. We did a survey of the resources that were available. We found out everything we could about our community that we were going to be serving within the 3 years before we had a hospital building, before we had any doctors. So that was, to me, a real telling bit of data, and we incorporated that data into the things that we were able to do with the hospital. So, for example, we ended up making the waiting rooms bigger because we knew we would be accommodating larger family sizes. our population is about 74% Latino, about 19% African American, and pretty much all Medicaid, Medi-Cal in the state of California. So we did make some changes to the hospital physical hospital based on some of the things we learned. We also immediately started reaching out and understanding what coordinations existed in this community. And we found that there were very little. And we sort of took on the role of catalyst ourselves because there were so many people doing such good work in the South Los Angeles area, but it seemed that none of it was coordinated, particularly none of it around health care. And so we have continued to work, and that will be a Mount Everest that we continue to try to climb because people do go many different places for their care. And while we're not, as Dr. Lopez is, near the border, we're some 100 miles from the border in San Diego. However, we do have a lot of our patients that get care outside of our community. They get care wherever they can, and many do still go down to Mexico to see physicians and to get prescriptions, which we would have no way of knowing unless they tell us. So I think what this study will tell us, one of the things I learned that I thought was interesting was the impact on the following through with the treatments of care if they felt respected. We have brought in a lot of staff. We made an effort to bring in staff that were from our community. We've got some beautiful educational facilities, a magnet math and science high school. We've got the Charles Drew Medical University that turns out physicians as well as allied health professionals. So we have made an effort to find the best of the best from our community so that this truly is a community hospital caring for its community. We have gone through staff training and diversity training, but there's nothing that can match the cultural sensitivity that someone has when they actually come from that community. So we've done an amazing job of hiring from within the community the best that that community has. And I believe that's been a big help.
Thank you. It's always good to understand how folks are I guess, dealing with these issues on the ground. Our next question is for Ms. Knight. The Foundation has been heavily involved in topics related to healthcare parity and equal access and improving experiences for vulnerable populations related to this topic. So in your opinion, how has the Foundation sponsorship changed the landscape, and what's the next area of focus in this space?
Hello, everyone. First, thank you to Alexis and colleagues at Foley and Lardner, and to Pari and Oliver Wyman for hosting today's webinar. RWJF's mission is to improve the health of all in America, especially vulnerable populations. The Foundation's vision is one that respects the American mosaic of diversity. So we believe that health should mean different things to different people. And at the same time, it's a view that provides all of us the opportunity to pursue health equally, no matter what our background or heritage happens to be. We are, however, painfully aware that under our current healthcare system, the quality, the cost, and the patient experience that many Americans receive is disparate, it's disorganized, and as Pari just pointed out so eloquently in the study findings, it can sometimes, frankly, be dismissive. Consumers are frustrated at the complexity of the information they have available to them. Information access is dissimilar for different people, which leads me to an important point about access. Often we think about access solely in terms of whether individuals are able to get in the door. It's much broader than that. Not ensuring that web-accessible materials are formatted for cell phones, for example, is one way we limit access to meaningful data that certain consumer segments would find useful. The absence of information in one's own language is another access problem. Complex information that is not accompanied by simple, direct, or clear explanations. These are all access issues and puts us at risk for widening the health disparities gap. In our current environment, especially where more and more consumers are needing to articulate their own needs access to resources like cost information is critically important, and it's hardest for consumers to find this. As providers and representative of health plans on today's call, you have a role to play, and it goes farther than creating more tools for the lowest common denominator. This research identified providers as one of the first and most prominent sources of information across all consumer groups. So it sort of begs the question about what are we doing to ensure that we're providing resources that patients need, and we're thinking about it in a way that everyone has access to it. The Foundation's investments have always sought to, and continues to, tackle the greatest challenges to good health and healthcare, especially in pursuit of solutions that are effective and equitable. Here at RWJF, we don't make policies, we don't sell anything, and we don't deliver any healthcare services. But we work alongside others because we share their dedication, and we recognize that our collective will can ensure that everyone has equal opportunity at achieving optimum health. We're seeing where public and private sectors are collaborating to make a difference. We're seeing shifts in mindset around what constitutes health, and we're seeing where individuals, families, and communities, businesses are prioritizing and shaping a culture of health. There's a tremendous need and an opportunity here that lends to all of that, but it's pretty clear that we still have a lot of work to do, right? Can people access the care they need? Do they have the resources that will help them make the best decision about what is right for them? Where can they expect to find helpful information? How people look for information to guide these choices and what they find looks differently population by population. So it's critical that we start to reflect on some of the information that we have and think about how we can partner across sectors to make sure that we're meeting the needs of everyone. I'll turn back over to you now, Alexa.
Thank you. Sorry, I thank you for that, and I think I think your last point is a very interesting one. Is sort of the ability to get across sectors, as a key ability to move into a space where we can provide everybody with the information they need. When working with stakeholders who may not be used to working so well collaboratively together. So thank you. My next question is really a question for the panel, and I'll ask this of everybody. And the question is, what do you think it'll take to really make a cultural shift in how providers view and treat vulnerable patients? How can health plans play a role in that? How has the Foundation been able to assist these stakeholders? We were just talking about this sort of across the spectrum in creating this transition. So I'm going to go ahead and start first with Dr. Lopez, if that's okay, from the health plan perspective, and then I will open it up to the rest of the panel.
Thanks for the question. I think moving from payment for service, fee for service, to value-based care is going to be an important way to move providers in that direction. And I say that because we've seen that in the STARS program with Medicare, where when the providers are at risk for their entire population, there is a significant improvement with health equity within that population. So providers will be incentivized to be able to treat all their patients equally, but not only that, actually their vulnerable populations may get additional care and services to be able to get them in line with a total population. So I think a value-based care model is important, and using alternative payment systems such as ACOs and other models to make sure that we have providers aligned with the interests of their entire population of patients.
Thank you for that. And Melaine, do you have any thoughts from the provider perspective?
Yes, certainly. I do. I'm a huge believer in pay for value. So I do agree with Dr. Lopez. The world I live in, though, I've had quite a bit of success in payment for value and risk-based payment. The difficulty with this population, at least that I'm dealing with in South Los Angeles, is data. It's very risky to start taking risk or start doing other payment mechanisms other than fee-for-service if we don't have data and we aren't able to reach those populations, and those populations are seeking care in a variety of other sources. So back to what I said earlier, there, in my community where we're working now, there is no systemness. The health plan data that we receive on our patients is lacking some of the main things that we would need, and I don't think it's any fault of the health plans. I just think the data doesn't exist today in a comprehensive environment. This vulnerable population, my experience with them is, as much as we don't want to hear this, many times they are using others' health insurance cards, or they're getting care and not using their health insurance because they're getting it outside of their community. So that the data is incomplete. And without having that data, it's very hard to move to any kind of a risk-based system. In California, we are one of the lowest paid Medicaid states. And so hence in my community, I've got 39 physicians per 100,000 population, where most others have 260 per 100,000 population. Getting physicians to come to this community with the payment system that we have currently in California is very difficult. What we are having to do is our friendly PC, our medical group model, we set up is set up as a 501c3 so that we can accept grants, we can apply for grants, because we will always be subsidizing physician payment as long as we've got the Medi-Cal reimbursement at the levels it is in California. We are desperately making inroads into managed care and managed Medicaid. We're just not at the point yet where we have, number one, the capacity. We're a brand new medical group, and as I said in the intro comments, we're opening our first site in 3 weeks. So Merry Christmas. We're going to be opening the first physician office in this community to open in decades. So we're excited about that, but still it's 2 physicians out of the 1,700 that we need. And so we've got a long way to go with raising funds and continuing to work with our health plan partners to come up with mechanisms to appropriately reimburse us for treating this vulnerable population. So I think we have a long way to go, but yes, I do agree with Dr. Lopez that paying for value is clearly the end goal.
So this is Mishi, and I'll just jump in here and say I so agree with a lot of the points that both Esteban and Melaine have made, but I think that if this move from fee-for-service to paying for value addresses one of the issues, it still doesn't really address the issue of information to help individuals make the decisions about the care that is right and that they need. And one of the things that Melaine spoke to is the unavailability of data. So I would just like to push a little bit and ask you, and perhaps Dr. Esteban as well, what it would take for you to make the investment that is necessary for the data that you're missing.
Well, it would take a lot of assistance from folks that have the funding and the wherewithal to do that. So first of all, it would take resources. Secondly, it would take cooperation of all of the population that we serve, of our 1.4 million people, because as I said, and I think Dr. Lopez has said, and we all are aware, the patients do get care in a variety of settings, and many of those settings are not accumulated in what you and I would know as the typical data sources out there today. So it would take a pretty intense effort. We are doing that with our health plan partners. I personally believe the health plans really need to take the lead on this. I think that is one of their fortes that they have, is to be able to cast a broader net, if you will, to get the data.
You know, health plans are evolving from what they were 5, 10, even 15 years ago. doing very different things for their members and for their providers, where maybe 15 years ago the bulk of the work was adjudicating claims, paying claims, and maybe doing some utilization management. Today you have to really be in tune with the needs of your member, and we have a variety of different members, from the traditional group members to the government program members, which may be Medicaid and Medicare, to what's called the retail population or the individual market through the Affordable Care Act, and really not understanding what the Affordable Care Act will be under the new administration. But that being said, there isn't a long history of how traditional health plans have a business case for health equity. While we understand that there is a moral case with regards to health equity and addressing health equity, I think more work needs to be done to prove the business case, because health plans will have to do a lot in terms of investment to be able to move the plan in that type of direction. So an analysis of the business case for health equity from the plan perspective will be important.
So this is Puri. Let me also quickly jump in and respond here. When we circulated these findings with a handful of individuals across the health plan and provider organizations to understand what these findings meant to them and what would be necessary to have them make the investment in provision of healthcare information or provision of better healthcare information at the right place at the right time, many of the sentiments echoed exactly what Dr. Lopez just said, which was to say, help me understand the ROI for doing this, because we know that it's the right thing to do, but our organizations right now are under tremendous pressure, not just from the turbulence that exists in the healthcare market, but also from the fact that margins in our business are not huge. So it's not like we have a ton of money to be able to think about investing in things like this, which we know are the right things, but don't necessarily have a business return that's immediately apparent. So, if we can get to a point where we can prove that, yes, provision of this type of healthcare information does help us reach some sort of better health equity standard or make sure that the population stays healthier all the way around, that would be very helpful. That's something that we heard pretty clearly at the conclusion of most of our interviews.
So, and before we move on quickly to our sort of scheduled questions, I'm going to actually take a question from somebody in our audience who has asked, and I think it relates to this this discussion we're having about proving the business case for all of this, but it relates to the question of how you're dealing with other socioeconomic issues that hinder these populations in managing their health. So whether it's financial, transportation, housing, food, et cetera, what sort of investments are being made there to sort of assist in better health as well, and what, if any, assistance support is necessary in order to try to address those issues. And I know this one's sort of off the cuff, so I apologize. But
this is Melaine. This is Melaine Yoakum. And what I would say is, as we have started the new medical group, we are not yet in a position to be able to contract for anything but fee-for-service Medicaid, Medi-Cal in California. But on our own and through funding from some very generous foundations that are supporting this, we are opening our medical group with an entire care coordination capacity. So that will deal with the socioeconomic issues of transportation. 47% of our population does not have access to a car. And in Southern California, that's unbelievable, but it is the case. And so we have and will locate our current offices and any future on the metro station pathways and make sure that transportation is available through other resources as well, so taxi vouchers and things like that. We've had a long history, even before the hospital was up and built, of working with community organizations around healthy eating and access to food. We are a food desert as well. And so we have done some work there in trying to, and have gotten the county to open a public health community kitchen where we're giving cooking classes. Our cafeteria is open to the public, of course, and we do publish nutritional data, and our cafeteria focuses on healthy eating, and we encourage young families through outreaches to the schools to come and eat at discounted rates in our cafeteria. So we are trying to address those. We've worked with the county to open a recuperative center, which is strictly housing for homeless or near homeless people who have had services in our hospital and can be discharged to this recuperative center so that they can heal in a better setting than the streets, and they can get meals that are provided to help them heal. I realize that's only temporary while they're healing from whatever they were in the hospital or ED for, but at least then we can speak with them and give them outreach to community organizations who can help with further food services and housing services. We've taught cooking classes to the Boys and Girls Club, kids 8 through 18. So we have been doing that and many, many more things in outreaches to schools and faith-based organizations that will hopefully come to fruition. It's not easy and it's not facile to do. We found many of the things that were found in this survey, that it's very difficult to go and search for these organizations. And there may be 20 in the community, but you have to get to all of those 20 because each have something to offer, and we need to be that resource for our patients. We at the hospital and the medical group do look at ourselves as the catalyst for bringing a variety of services together to improve the health of our community. So we very much are doing that in our medical group and our hospital discharge planning.
And similar to that, we work with social workers that we hire internally and community health workers that may address these issues that come up with some of our patient members to be able to help manage those needs, and oftentimes these are flagged by case managers that may be working with some of our members. And we understand that if we don't address the social issues that may be affecting some of our population, then we're not going to be able to impact their health issues at all.
Hi, this is Mishi again. I'll just jump in here to quickly say, I think that this is right. We have to undergo a fundamental change in our perspective of what constitutes health and think about it more broadly. I think one of the things that has resonated with me from the research that Puri and Oliver Wyman did is that even individuals with multiple chronic illness say that docs often focus on disease conditions rather than well-being. So I'm listening to Dr. Esteban, and I'm listening to Ms. Yoakum speak about what they're doing and the collaborations with the communities, but I also wonder how this also trickles down or impacts the providers and how they are making the connections and providing the information and the resources that their patients can see them as much more of a connection to health care, but also more of a connection to health and well-being.
Well, so this is Melaine. We are just opening our first office in a few weeks, so I don't have a lot of experience with the providers. I'm assuming you're defining providers as physicians and allied health professionals, or are you using a different definition of providers?
Physician and allied health professionals, and perhaps even just the systems themselves, how they also are making the healthcare connection much more evident for all the individuals who work.
Yeah, our first office isn't even open yet, so all I can speak is the past year experience with the new hospital. But I will say that our providers and the staff that support them have been trained and have continuously been getting updates, as we know of them, of community resources. And they follow up because this population has had very little care in such a long time. We feel like we need to continue to outreach to them. It's not just give them the discharge plan and wish them well on their way. We've really continue to try to outreach to them to make sure that they didn't have problems, or if they did have problems, can we do anything to help streamline that? Because truthfully, it is our mission. This is what we need to do, is to continue to improve the health care in South Los Angeles, and we need to do it a little differently than we would do in a non-vulnerable population. So we've taken that upon ourselves only because we know that this is a difficult community to navigate. And so I think it's just continuing to do that and only increasing that as we move forward.
And I would say from the physician perspective, there needs to be more training in medical schools and residencies. Most physicians are not trained to deal with vulnerable populations in terms of the social issues that they may face. We're trained to take care of patients and their diseases, but really a holistic approach to managing patients, especially vulnerable populations or populations of color, from a cultural competency perspective is important, and I think medical schools across the country need to step up.
Yeah, this is Marie again from Oliver Wyman. So we heard something very similar, Dr. Lopez, from people that we talked to, right, especially given that there is this issue of non-adherence that goes hand in hand with respecting vulnerable population individuals, being culturally competent when you're treating them, etc. There was a lot of debate actually that was had with a couple of individuals in terms of training versus education. So we talked a little bit about what education would imply, and certainly medical schools need to step up and play a role here. But there is a huge role to be played in terms of physical training. I'm quoting directly one of the individuals that I spoke to from a health plan, who is the chief medical officer of the health plan. And when I told her that, the feelings of disrespect or, not understanding where a certain individual was coming from when they came in to get their care, she said, well, what are you going to educate them on? She said, you can't educate them to look people in the eye. You have to accompany educational programs with real hands-on training. So there's a huge opportunity for that too, I feel, to make sure that these types of populations, that these individuals are appropriately taken into account during medical care.
This is Melaine Yoakum. I mean, in addition to that, I think it's a desire to serve this population.
Exactly.
Personally, I don't think you can train somebody to do something that they aren't passionate about. So hence going to look in our community, going to the medical schools there and the schools there that are producing top-notch students that are culturally competent and come from that culture and want to serve that culture. It just thrills me to no end to see the providers who have been off at UCLA and USC and other places around Southern California, and when this hospital opened, came back and asked to please have a role to play. This is where their heart is. This is what they've been waiting for, is some kind of system in this community that would be able to let them serve where they came from. So I think it's training, yes, it's education, yes, but it's heart and soul, and that's what has made the difference, I think, in the way our hospital feels to this vulnerable community.
And then I'll address, I'll talk about the elephant in the room, which is reimbursement, right? That's the other thing that obviously needs to be taken into account. Part of the reason why many physicians don't want to serve this population is because for many hospital systems, et cetera, it can end up being a money-losing enterprise.
Well, thank you very much to our panelists. I think they've left us with some very, some interesting food for thought and perhaps the topics of the discussion for our future webinars. Unfortunately, we have hit our clock. It is 3 o'clock Eastern Time. For those of you seeking CLE credit, on your screen right now, the code to be entered is M like Michael, 8. It says M like Michael, the number 8, K like kangaroo, N like Nancy, 6. Again, that's M like Michael, 8, K like kangaroo, N like Nancy, 6. And I'd like to take a second to thank all 4 of our panelists This has obviously been an interesting discussion, something that's very close to a lot of people's hearts. It leaves some questions as to, what the next steps are for providers, for health plans, for our policymakers with respect to reimbursement, and as the healthcare sector is poised for change and for care redesign, it's good to know that we have passionate folks like those on the phone who are here to help us make it through. So on behalf of Oliver Wyman and Foley and Lardner, thank you very much to everybody. For those listeners who didn't get a chance to answer your questions, we will do our best to reach out to you after the webinar. And please feel free to reach out to Oliver Wyman or Foley and Lardner if you have any questions. Thank you very much to everybody for your time.
Thank you so much.
Thank you very much.
Thank you.
Thank you. Bye-bye.
This concludes today's conference call. You may now disconnect.